Okay, welcome. I'm Marie Harvey, the Associate Dean for Research here in the College of Public Health and Human Sciences, and I'm just delighted to welcome you to this seminar. This is our Friday seminar, and this is the second one in this fall series, and we're having it at Nobles in person. So those of you who are joining us in person, thank you for joining us, and by Zoom. So for those of you coming in remotely, I hope you can hear okay. So I don't want to spend any more time. I want to give the time over to the speaker, but before doing so, I'd like to introduce Sam Johnson. He is Associate Professor in Kinesiology in the College of Public Health and Human Sciences, and he will be introducing today's speaker and moderating the session. So Sam, it's over to you.
I'll just take this one. Thanks, Marie. So welcome to the college's Friday research seminar. We're so glad you're able to join us today. We have participants here in Hallie Ford Center, but also on Zoom. So if you're joining us by Zoom, we have set it up as a webinar function. So you'll need to, your microphones are muted, and your questions, you can use the Q&A feature, and we'll ask those on your behalf. Today's presenter is Dr. Marc Norcross. He is an associate professor in the Masters of Athletic Training program and the graduate and undergraduate kinesiology programs at OSU. He arrived at OSU in 2011 after completing his Ph.D. in human movement science at UNC Chapel Hill. And prior to his doctoral work, he worked in the Department of Informatics at UCLA. He currently serves as the kinesiology graduate program director. And outside of OSU is the chair of the National Athletic Trainers Association Research and Education Foundation Research Committee, and is a member of the Oregon Physical Activities Association Sports Medicine Advisory Committee. An athletic trainer and biomechanist by training, he utilizes both lab-based and population-level approaches to understanding, improving injury prevention strategies. Please join me in welcoming Dr. Norcross.
Thanks, Sam. Bear with me one moment to get this up. And Jacob, can I close this? Is that okay?
Yes.
Okay. Almost there. All right. So for coming and Sam for the wonderful introduction. And as Sam mentioned, by training, I'm a biomechanist, but everything today that we're going to talk about has little to do with my doctoral training, but a lot to do with clinical training in respect to actually trying to make a difference in injury prevention on a larger scale. And so title here is Variety is the Spice of Life, and really we're going to talk about how can we perhaps engage stakeholders to better implement injury prevention programs. And you never want to kind of give away the lead at the beginning, but at the beginning, but essentially people don't do these things on their own. So how do we kind of increase that uptake? And so I do want to have, maybe? No, I can do it. I can walk. Okay, I do want to give an acknowledgement to a collaborator of mine, Alex Donald, is at La Trobe University in Australia. The book or the concept of this presentation was actually one we developed together that was intended to be given at the IOC World Conference on Injury Prevention and Illness in Sport. Unfortunately, I can technically go, he can't live in Australia, so we backed out and I had to give it here instead, but just want to acknowledge him on that. Conflicts of interest, some of this work was supported by the Oregon Physical Activities Association Foundation, and as I mentioned, I'm a current member of the OSA Medicine Advisory Committee. These thoughts are my own and others. So why worry about ACL injury prevention? So in a clinical perspective in sports medicine, we worry about this a lot. One, because it's relatively common. I say relatively because it's one that you see usually on a team at least once a season, or maybe once every other season, depending on the sport you work with. That said, in the grand scheme of knee injuries, it's not really that common. In other words, if I'm a coach of a women's soccer team, it's not a necessity that I'm going to see an ACL injury this year. And if I do, I might only see one. So it's kind of like, it's common enough to be problematic, but not so common that it oftentimes presents as a major burden to coaches. In the high school level, when we look at kind of injury patterns, what we see from the high school Rio study is that knee strain and sprains, more generally, of which ACL will fall into, are pretty common in terms of injuries that individuals suffer. These are time loss injuries, counting for 7% of all injuries that can possibly happen to high school athletes tend to be knee strains or knee sprains. When we dive down into ACL injuries specifically, of those knee injuries, they account for about 20%. And so some gross estimates here, but high school sports alone, not just high school age, but actually high school sports alone, nationally there's an estimate of about 35,000 ACL injuries per year. So again, it happens a fair bit, but it's not one of those that may happen every single day. So with that said, why do we really care about this? And some of this is that there's some serious short-term impacts. So we do know that following ACL reconstruction or ACL injury, for those who want to go back to activity, they tend to need to undergo an ACL reconstruction. Timeframes here will vary based on graft type or also the surgeon, but generally they're looking at 9 to 12 months of restricted activity before they could go back to their sport. The real problem lies in once they've had these injuries, in the first year after returning to sport, they're 15 times more likely to suffer a second injury. And that injury could be either to the ligament that was reconstructed or to the opposite side. If they make it through the first year and get out to the second year, they still remain 6 times more likely for a second injury. So some of this could be due to insufficient rehabilitation and clearance guidelines, and I was kind of trying to look at that. Other things here could be that perhaps we're not very good at identifying what was the precursor or the risk factors for the injury in the first place, and almost trying to improve those movement patterns prior to them going back to play. Long term, these patients, sure, they can come back to play, but it's at some significant long-term disability. So up to 50% of these patients display evidence of knee osteoarthritis within 10 years after their injury. To put that in perspective, if we're talking about a high school athlete, we've got 14, 15-year-old athletes who are going to have knee osteoarthritis that is able to be picked up on X-ray by the time they're 24 or 25. And so these are some serious burden to long-term activity associated with that. It's proposed that up to 100% of ACL reconstructed patients are going to have evidence of OA within 20 years. And so we know that once this occurs, they're in for a difficult challenge just to get back to player activity. But we also have the onset of degenerative changes within the knee that are going to impact their physical activity going forward. And so all of that, in terms of both short-term costs, quality of life reductions, and all, there was a study by Mather in the Journal of Bone and Joint Surgery that estimated that in the US alone, the economic impact of ACL injury is about $7.6 billion annually, all those costs put together. So relatively kind of rare injury in the grand scheme of sports injuries, but a really big negative consequence. So because of that, this idea of ACL injury prevention programs and developing these is not anything new. I went to this one as most recent, but there have been so many studies done and meta-analyses done that there's actually a meta-analysis of meta-analyses talking about ACL injury reduction training programs. This language about our injury reduction training program, I'm going to use the term prevention. Some people in this field have kind of gone to reduction that say, well, you can't prevent them all. I'm of the mindset, well, I'd like to prevent some of them. So I'm going to call it prevention and try to prevent a few of those, then just try to reduce the overall. And so this was published in 2018, and really all of these meta-analyses, the meta-analyses really showed that these programs work. They tend to result in a reduction in the rate of ACL injuries. And they also seem to result in the rate of a reduction of other kinds of lower extremity injuries, even though they weren't designed to reduce them. So things like muscle strains, ankle sprains, other kinds of things that would be associated with this. So the idea is that yeah, ACL injury prevention programs really work. And so this is kind of just the forest plot from there. And what we tend to see is that by and large, all of those meta-analyses had a favorable effect. And this was an estimated kind of 50% risk reduction if people were to use these injury prevention programs. So not that that article was published at the time, I had this next kind of slide developed, but you know, I was fairly new to OSU 2013 and come in. This was the world I'd been living in. So lots of skin markers, biomechanical models, looking at motion capture. But at heart, I was also an athletic trainer having worked clinically with patients with ACL injury. And I went to a conference in North Carolina, dubbed the ACL Injury Retreat. And so, and at that conference, there was quite a bit of studies that are all looking at risk factors. Is it hormones? Is it movement patterns? What is this? And there were very, very few studies that actually were like, wait a minute, we have these things that actually work. Why aren't we talking about like how to get people to do them? We're just so interested in still trying to figure out like, how do we create the perfect program? And so I sat on the plane on the way back and got settled for a while. And I remember this looking out the window because it was mountain. No, and I had this epiphany of like, well, why don't we just go try and do this in our community? Like, what? Okay, the risk factor stuff's great. Let's kind of do those kind of studies, but let's go out and try to see here in Corvallis, can we get people doing injury prevention programs? And I remember coming back, talking with Sam, Mark Hoffman, and we said, sure, we'll go do this. Like, they're friendly. We'll go to CV, we'll go to Crescent Valley, and we'll go to Corvallis High School, and we'll say, here we are, coaches. We're here to help you. Let's do an injury prevention program. And we were kind of met like that. Right? And I vividly remember a conversation I had with the head basketball coach at Corvallis, who has since retired. Very nice guy. I don't know what he actually thought of me at the time, listening to me, because I'm brand new. I'm telling him how great this is, all the things he should be doing, totally the opposite way of what you should be doing and what he should be doing. And he looked at me and he said, that sounds really good. I've won 5 state championships the way I do things. And I do most of everything you just talked about. Thank you, but no thank you. And I turned and walked away. I was like, well, okay, what do we do here? And so this idea of implementation, I was not familiar with, but it really got us thinking about, holy cow, there is, and it's not novel, this idea of this bridge between practice and evidence-based and practice, and this translation of evidence. And so I felt at the moment, here we are standing on one side of the bridge. We know these things work. Why aren't all these people doing this? Like, why can't we get folks engaged in doing this? And I think a couple of different layers to that. One of the challenges I see is that, you know, the people we're trying to help are the student athletes on those teams, but they're not sort of the gatekeepers about whether they do the programs or not themselves. It's the coach on the team. So you've kind of got this factor leveled in that if you get that out to the athletes, the 14-year-olds, you kind of got to go through a conduit to a coach, and they're not the one who's actually going to suffer the injury. So that creates a little bit of a dynamic. The other kind of thing we start to see with these programs is that they tend to be developed and geared towards certain sports. So some of the common ones that you may have heard about are like the FIFA 11 Plus program. It's really hard to walk to a basketball coach and say, hey, you should do the FIFA 11 Plus program, because they're like, that's a soccer program. I do basketball. How does that work? And so there's some challenges here in getting them out into the public. Beyond that, they're just all the general challenges of translation to practice, kind of these classic slides related to how long does it take for evidence to turn into practice, and the answer is 17 years, which doesn't help you very much about how you actually get that into play. Many times, though, this is because I think it's changing, but people weren't as purposeful about thinking about the end product of actually how do you disseminate that well, and what are the barriers and things to disseminate. It was more of a we created it, you will use it kind of approach. And so, which maybe after 17 years, people do that. So I think for many of you, I see faces are probably more kinesiology students, so this was new to me, maybe new to you, but I think it's important that we create a distinction between the concepts of efficacy or effectiveness. I promise you, I made this slide pre-pandemic, but it still holds, that efficacy is really this idea of does the intervention work, right? Oftentimes that's done under randomized controlled trials, very tightly controlled conditions. Effectiveness, or excuse me, and that would be this idea of this is an influenza vaccine. I didn't put up a picture of a COVID vaccine, but this could be, that does this vaccine work? And so sure, we can do these trials and show with experts 86% efficacious at preventing infection. Well, effectiveness is, does it actually help people? Does it improve population health? And for that, you actually have to get it in people's arms. So I think this slide probably isn't needed now like it was 5 years ago, but this is sort of the problem. All of those studies that I had mentioned had very specifically dealt with efficacy studies. They've gone into teams, tightly controlled conditions, researchers there every day, monitoring, do these exercises, do these kinds of things. And what do you find? Oh, wow, they can reduce injury. And so whether it's kind of doing them in soccer, doing this in high school settings, doing this in a collegiate setting, they all had this sort of artificial environment, which was researchers come in, we give you this thing, we watch over, we do it, and then we leave and we take our numbers and we show, see, our program works, right? But that's not really how the real world works. And so when we look at this, one of the things I've leaned on, excuse me, is some work out of Australia, Caroline Finch and again, Alex Donaldson, who have taken sort of some basic tenets of Glasgow's re-aim policy and applied it to sports injury. And so they really call it a sports setting matrix for implementation context. And so they basically have this, they take this framework that say, well, how do we actually do injury prevention? And so the injury surveillance part, or step one, has been done. Some of those initial slides that, yeah, we know this is a problem. We know roughly how many are occurring. There have been plenty of prospective studies that have at least established etiology and mechanisms of injury that contributed to the idea of, oh, maybe we have to strengthen this muscle or teach certain kind of landing patterns or safe ways to move. They've done stage 3, developed these preventative measures, created these programs, and they've done step 4, which was really to look at this in controlled environments and said, are these efficacious? One of the challenges at this point in time is we're kind of stuck at step 4. You know, we have these programs in tightly controlled environments that have been shown to work, but very few people up until that point, and it has changed slightly since then, have really tried to understand the context of where do these programs have to be used? Whether the people are going to use them, what do they think about these programs? Will they use them? Why don't they use them? What other barriers do they have? And only until we understand that can we get to step 6, which is this idea of, okay, we might have to take those programs, modify them in some manner so that they're actually used in the real world to ultimately and hopefully get back to this stage where we can say, all right, are we now having impact in reducing the number of, in this case, ACL injuries, okay? And so as I learned a bit more about this and worked with our group, we kind of sought to look into this and say, well, let's try and clear the fog here a bit and understand what is happening. What do coaches know about these programs? And up until that point, we really didn't have much of an idea. And so the data I'm about to show actually come from a subset of 15 schools that we recruited across the state of Oregon, various locations, sizes. Only constant here was they all had athletic trainers. We've done some preliminary work and really saw that the practices of coaches with or without an athletic trainer didn't actually influence what coaches' responses were. But we kind of sought these 15 schools and we went in and, not a very catchy title, we wanted to say, what do you figure out, what in the world do you know and think and actually do, more importantly, about injury prevention? And we leaned on this sport setting matrix as well, in that Finch and Donaldson had basically taken this matrix and applied, I got ahead of myself, the re-aim dimensions of Glasgow. And really the idea here is, how do you assess an intervention in terms of reach? So how many people are actually aware of it? You know, who's the target audience that you're able to get it to? Second kind of piece of that is the measures about effectiveness. So effectiveness is, do they perceive it to be useful? Like so I may know about it, but if I don't think it's effective, I'm likely not to use it. So what are my attitudes relative to the intervention? Third step is, okay, I know about it, I feel good about it, do I actually use it? So do I actually adopt it? Third is implementation, is then, okay, I've chosen to adopt it, so how do I do that? Do I say I'm doing it, and I totally change the program and do something else? And then finally, maintenance is, do I do that over time, or do I do it for one season and then go back to my usual practices? And so we kind of looked at this at really a team level, and they had some specific questions we drew from to really assess these various dimensions. And so some work we published in 2016, this was now, the team had grown to include Victor Boberg from epidemiology, as well as a sports medicine physician from the Slocum Institute down in Eugene, Dr. McKeister. And we sort of went out to these high school coaches, and we asked the simple question: are you aware of these injury prevention programs? Do you know they exist? And what we found is only about 55% of high school basketball and soccer coaches were even aware that there were injury prevention programs in existence that have been shown to reduce injury risk. So right away, we're lost the battle for 50% of them. They didn't have an opportunity to even make a decision about it. We then said, okay, if you know about them, do you adopt them? And so what we see here is that of all of those coaches, even the 50% who knew, less than half of them actually then adopted one or used them with the team. So they knew about it, but I'm not going to use it with my team. And then finally, it's not enough maybe just to say you're doing it. We asked, and this is still self-report, so there's no guarantee they were actually doing it as designed, but we at least asked the question of, do you use it as designed? And only 9% actually said, yes, we do it as designed, which means there's only 9% where that's even a chance that happens, right? Who knows if those 9% really actually did it as designed. And right away, we were struck by a couple different things. Number one, coaches don't know about this. So we've got to figure out, how do you amplify the message of what's available? Secondarily, there is an issue somewhere here related to, sure, they know about it, but they don't actually do it. Why aren't they doing it? What is the problem here in terms of why they don't choose to do it? And then if they do it, why are they changing it? Right? Why are they doing that? And so we built in some other couple questions where we've tried to assess attitudes about these. And the way we tried to look at these attitudes is to try to differentiate, do these things differ in coaches that use the injury prevention program or don't? Trying to find a hallmark of, well, maybe that's a factor we could address to get the non-adopters into the adoption set. And what we're trying to see is that, you don't have to read all of those, but they generally had really positive attitudes about these programs. Lower extremity injury prevention is important. They should do it. It negatively impacts game performance. I would implement it if it was proven to treat lower extremity injuries. Probably not true because they're not implementing it, but they said they would. And I would implement it if it was proven to improve player performance, which they actually as well. And yeah, so this kind of, there's nothing about their perceived their perceptions about the program itself that seem to be a barrier to them using it. So what else could it be? And we started to ask some questions about, what are some other things that are important? So should players come to training? Yeah, they should come to training. Some of these are thrown in. Should coaches have knowledge about lower extremity? Yes, they should. Okay, that's not it. Should training sessions improve performance? Should players have knowledge about lower extremity injury prevention? Yes, they did. And then finally, we got something we could perhaps see something where a fair number of these, the lower extremity injuries aren't a problem for my team. They're not a problem for my team. And so getting back into what this means is that we leaned on some work of Rogers called Diffusion of Innovation. And so one of the things that needs to happen for someone to adopt anything, and preventative measures are one of the hardest ones to adopt because you're asking people to do something to try to prevent an event that may not actually happen, right? And so that becomes super, super tough to do, is that these coaches are sitting there like, sure, these programs exist, I feel good about them, but they don't perceive the problem to exist on their team. So there is no chance that they are actually going to adopt those measures because it's not an issue for me. Right? And in their defense somewhat, given that kind of information, it may not seem like a problem, right? Maybe they only see one ACL injury every 2 or 3 years, but they're not seeing more of the global context of how impactful even one injury is in the life of a child. And so this became a place that we thought, maybe we could have an avenue to kind of talk to coaches about what the issues related to those injuries would be, as a way to kind of upsell them. Other things that we went and really focused just on the coaches who weren't adopting the programs is common, some more commonly kind of cited excuses perhaps of why they don't do them. The programs cost too money. My team's practices are not long enough to devote time to the injury prevention program seem to stand out. The way most of these programs are structured is they're either done in addition to the practice and training sessions that have been set up, or they've been positioned as being a replacement for what had been done as a warm-up. And so if we think about that functionally, what you're asking a coach to do is you're going to say, you do an injury prevention program, they think it's a good idea, they want to use it, and they say, I don't have the 30 minutes extra in time to do it with my team, or the only other way this happens is you want me to stop what I've chosen and have done for my warm-up practices and do this other thing. And we're basically saying, we know better than you. And then we're surprised somewhat that they don't do that, right? And so this idea of time becomes an issue. And they have also explicitly told us, I already have my student athletes perform these type of activities. So some of them sit back and they look at the programs, they're aware of it, and they don't distinguish what they're doing from what is contained in the programs. And so another kind of, in this article, we kind of laid into some of the context of diffusion of innovation that we have some challenges now. One is that many coaches don't see these programs as a relative advantage to what they're already doing. If something's not a relative advantage, you don't have any impetus to want to spark change in your behavior, right? Other challenges, they're not compatible. You know, sometimes they see this and asking me to do something after practice is not compatible with what I have, or I'm using a program that isn't actually, I'm using a soccer program for a basketball injury. And the other part that can play into that is this notion of complexity. So does it kind of fit within the structure of the way they're interacting with it? And that doesn't seem to match as well. Lastly, kind of the last one that really held out that was interesting to me at least, is that some of them didn't do them because they didn't think their student athletes wanted to do them, which is again an education component of, well, I can say this now that I have a 15-year-old daughter. She doesn't always get to decide what's most important, right? And so at some point of being the adult in the room, perhaps you need to make a decision about what that may be. And so, and I mentioned this one, I apologize again before, that they don't want to change the activities they're doing. So we followed this up. There was an undergraduate kinesiology student, Ellie Morgan, who's now a DPT, who looked at this, switched populations a little bit, did club soccer coaches in Oregon and Washington, and found much the same thing. The only other kind of extra found is that as these teams were older, coaches did seem to use these programs more, partly because they started to see the injuries were more of a problem in the older age group. So they better aligned with what they wanted to do. So where we are right now is this idea of we're shouting at people to do IPPs, but we're not doing anything to address the barriers or the reasons they're not using them. And so after we kind of understand a little bit better this intervention context, we can start to see that these are wonderful, but they don't fit what people need to do. And so we kind of took a step back and overarchingly looked at, well, what in the world should be included in an ACL injury prevention program? And there was a position statement released by the National Athletic Trainers Association, and they made a very straightforward kind of conclusion that said, multi-component training programs need to include feedback regarding technique. So it's some piece you have to provision instruction, and if they're doing a jumping activity and their knee's going like this, do you give them instruction on how to land? But then also, not very specific, but include at least 3 of the following components: strength, plyometrics, agility, balance, and flexibility, any of the 3. Where this came from was basically trying to look back at a couple of the previous efficacy studies and really looked at the activities they were doing. That's where this arrived at. A former doctoral student, Anita Huang, as well as Colin Mulligan, came forward and said, well, we've got some challenges with some of those efficacy studies because they didn't control for clustering, they didn't really calculate injury rates. And so as a result of Anita taking a class actually with Dr. Marit Boberg, they came up with this idea, included one of our APA students, Jae-Hong Yoon, who came in and did another amount of analysis where they just wanted to look at ACL injury prevention programs that kind of address some of those methodological challenges and just streamline it to the ones that were high quality studies. And that was part 1. And then the second thing they really wanted to do was evaluate what kind of components are in those programs relative to what the best practice statement of the NAT position statement actually said should be there. And what do those look like? And not surprisingly, they found ACL injury prevention programs work, right? By and large, this overall effect size, there was a reduction in ACL injury rates when you used an ACL injury prevention program. And I think my favorite part of this is that on the left-hand kind of second column, they categorize whether or not the items in that program met or did not meet the NAT recommendations. The only one where at least the point estimate was to the right and not showing they were favorable was the only program that didn't meet those recommendations. They also did yeoman's work to kind of super small, much smaller than it was on my screen. I apologize. I'll walk you through this. Is they basically characterize what are those activities in a program. So they looked at each and every category independently and said, which of the activities in the exercises is that a strength activity, a plyometric activity, an agility activity? And then they came together and kind of achieved consensus to categorize them all. And maybe the slide does work because the findings are as missed as the slide. What they found is that all of these programs, or many of these, include these components, but what those exercises look like are all over the place, right? There's all different kinds of ways to do strength or plyometrics or flexibility. And if we kind of think back this idea of provisioning feedback, or depending upon different ways that you would do those categories, at the end of the day, all those actually kind of worked. It didn't seem to matter. You didn't have to do straight leg raises. You could do something else. You didn't have to do box jumps. You could do a cutting activity. And so it gave some opportunity. And what they really came out with is this idea of, can we have some flexibility? So can we not just scream at coaches anymore about go do these things, but perhaps we can leverage some of the best practices related to injury prevention programs, coupled with what we know they're not doing, to integrate those principles into practice. And so this idea here is that, yes, some of this increased uptake could be through better communications, champions of programs to coaches to make them aware in the first place. But that's not going to solve the issue of coaches not deeming them relative advantage or not wanting to change their practices. And so the second piece became up of, well, stakeholder engagement. Maybe we could engage these coaches. Maybe we don't have to ask them to change everything they're doing, but perhaps there's an opportunity to go in and ask them, what are you doing? Tell me what you're doing, and look for the places where there might be slight deficiencies and just help them add those things in. Probably much more beneficial effect there to just say, we don't have to change everything, but just add these few components. And so if this were to work, then they probably need to be doing some of these kinds of activities. And so things come full circle sometimes. And this was some of our earliest work kind of all across Oregon, where we had asked coaches, do you do these kind of activities? And by and large, when we look at the percentage of coaches who do these activities, outside of balance, more than half the teams have a coach who say they do that. Now they're scattered, not everyone's doing everything, but these tend to be relatively common things done with teams. They wouldn't be completely out of the ordinary to ask them to do. What's less ordinary is that, well, are you doing enough of them? And so, these may be 3. Is kind of the minimum that we'd see. Many of those programs had a few more. But the other kind of key piece here is that what wasn't asked at the time is, are you provisioning feedback as you do it? So are you kind of doing that with feedback at the same time? So I think where we are at this moment is we really have this opportunity to kind of take a approach where we flip it a little bit. And we say, we're going to look to try and engage with our coaches in multiple different ways. Can we engage on, say, like a state level or through Oregon Athletic Coaches Association to get the word out about programs? Can you use individuals that are within school systems, perhaps athletic trainers or other individuals trained in this, to go to coaches and say, look, we're not trying to change everything you do, but what do you do for your warm-up? For a certified athletic trainer, it wouldn't take them very long to hear what a warm-up is, be able to identify some programs, and also maybe give a quick education about, can you give this feedback? the other beautiful part about the feedback was that feedback that was provisioned in programs didn't always have to come from a researcher. Many times it didn't. So some of them trained coaches to give feedback. Some trained, other athletes to give feedback to teammates. There was a component of kind of teaching people how to do that. But the feedback can come from multiple places. Some was video feedback. And so we can kind of have this opportunity to do a real world effectiveness study. And I wish this image could be changed, but this may be like the COVID fog that just as we got to this point, our ability right now to get into those high schools is kind of paused. So as soon as those high schools are now open, kind of the next step in this research line is to take that theory and try to put it into practice. Have a good solid evidence base of what might work and see if we can get back into the schools and probably at first glance, not actually look all the way back at the outcome, right? But really make it focus more on the implementation context. Do a bit more of a study design really to assess aspects of the RAIN framework when it's applied in a manner that isn't us on high telling them what to do, but rather trying to engage with them, give them more of a dynamic kind of method to do these injury prevention programs. And so it's one that I'm excited about. I hope maybe next year we'll see. I think high schools have been, I think they just want their doors open. They don't want anybody inside right now. So we need to give a little bit of time to allow us to get back in. But it is also one I think that, Sam and I, through some of our work with the OSAA, we've gotten to know and build relationships with some people through coaching associations that I think can be a viable kind of next step that we can do. And so I do want to make sure I thank Sam, Mark Hoffman, Victor Boberg, Anita Collin. Many people kind of have gone into this idea. I also think maybe just for half a second on my time is for students in the room, I had no idea what this was during my doctoral training, right? If we go back to my biomechanics, that's what I lived in. So I think what's most important maybe as an example is that you can perhaps take what you're passionate about, and maybe biomechanics was a skill to look at that problem. And if you can engage with the right folks with a good skill set, can you try and maybe change the way you approach that problem to be something you would have never imagined doing? And so hopefully we can kind of change this into this, which is everybody doing injury prevention programs. But that is kind of the next step here on our pathway. So thank you, but I will get questions in a sec, but I'm going to do a quick plug in that for those in here that the people I mentioned, as well as some others, so Dr. Tao Lee, Christine Pollard, Alda Cascade, JJ Hannigan, we've got other students here, Mike, Kyle, Demetris. We have a really, really terribly named lab group, and there's no easy way around this. It's because it's a sports injury prevention research group. And the reason we settled on this name, Kathy Kroll as well, is because the overall mission of our group is to prevent and to increase physical activity and reduce sport-related injury, and whatever that looks like. So we have, and many of the students are really doing things within the laboratory. They do biomechanical studies, motor control, could be aspects related to performance that are more of the traditional in-house studies. We also do a lot of work, as I just described, in the community. We also do work, quite a bit of work with the Pac-12 conference where, Kathy has a grant right now looking at overuse injuries and burden on athletes. We just got some funding to look at disparities in utilization of care among Pac-12 athletes. And so lots of different approaches. And then we worked with Tao Lee from Health Policy, where we've done some work really looking at the economic impact of athletic trainers and how that impacts individuals with Medicaid versus private insurance and kind of the value that an athletic trainer would have for access to care. And so maybe need to be more creative with the title, but if you are online or in the room and have any interest in sports injury prevention, please seek us out. We kind of cover the umbrella, all sorts of approaches, all sorts of populations with that end goal of just trying to increase health and physical activity. All right, I think I met my timeline, maybe over a minute, but thank you very much.
Mark, if there's questions in the room, you can address them here. If you're online, you put them in the Q&A, and we will repeat them.
I have two. The first one, when you were talking about ACL injuries, so is it more common in high school athletes?
Not necessarily. I think you would probably see the most number just because there are more participants. But from a rate of injury perspective, they don't occur at an increased rate in high school athletes, but there's just a bigger population. It's a similar kind of thought in, or actually slightly flipped, is that many times people associate ACL injury to be a female athlete issue only. And the reason for that is there are more female athletes sustain ACL injuries at a higher rate than males. When we look at the absolute number of injuries that occur within the population, males actually suffer more ACL injuries each year than females do. It's just they suffer them at a decreased rate of injury. And so these kind of programs have primarily been used with female athletes, but they also have been shown to have beneficial effects when the sample has been a mix of male and female athletes. Oh, you had two, right?
I did have another one. I'm sorry. Thank you. My other question was that if you stated, so the high schools that you went into, it was the coaches that you were talking to, but all of these high schools also had athletic therapists in them?
They did, yeah. And so just for that one, I think the sample lended itself to, we had doing some injury surveillance with them as well. And so the other part about having the athletic trainers there was one of the drawbacks to the initial one where we kind of broadly sent out an email is we couldn't really actually determine a response rate. It's a lot of these high schools, they have coaches from the community, the way they hire them, and you don't really know how many coaches there are. So you get this, you don't really know sort of what the response rate was. And so by limiting it down, we could actually then have the athletic trainer and the athletic director at the school kind of tell us this is who we have employed, so we could get a firm response rate in those schools.
Thank you very much. Great
presentation. Awesome presentation. When you guys are thinking about doing this next step of implementing, have you guys thought about doing some kind of cost-effective analysis or cost analysis? Just because injury prevention programs are usually super low cost. You're not using tons of equipment. That's mainly just time, and you're talking about changing huge economic impact. So it could be great evidence.
Yeah, I mean, I think it would be a couple different levels. So yes, doing a cost effectiveness would be wonderful for multiple reasons. One, the way we would probably go about trying to do this is to target high schools that have athletic trainers in them. It's how we can kind of have a bridge into those communities. Doing cost effectiveness could actually be beneficial more for the profession as a whole, because you may actually then be able to substantiate athletic trainers within the profession. One of the challenges with the cost effectiveness study there is that to power it appropriately to actually show a true reduction in ACL injury risk becomes really, really challenging unless you have really, really large sums of money. So the first thing we would probably have to do is a proof of concept of just looking at the implementation factors and going in and saying, we're going to take a subset of schools and we're just going to assess how does this approach increase the adoption, implementation, maintenance of these programs within this grouping, to then spin that to say, look, our approach actually does all of those things in a way that's evidence-based that should reduce injuries as a kind of to substantiate a bigger grant ask to then actually look at the outcomes on the back end. And so I think it is an important piece. Especially that they are lower cost, but they're not no cost. And especially in this environment, you say go to the athletic trainer, but that's one more thing someone has to do that they haven't done previously. So there is a bit of buy-in there that needs to happen. And so it is an important piece, but it may be kind of like a second stage.
So very good, wonderful presentation. So one of the things I noted is you really did create this very interdisciplinary team. So two questions. What motivated you to build an interdisciplinary team, and what kinds of facilitators and barriers did you encounter in doing so?
Yeah, so the honest answer is I was at least smart enough to know what I didn't know. So I recognized what I wanted to ask, knew where my limitations were, and tried to identify folks and see if they had an interest to engage that way. And so Victor was engaged because we wanted to do some injury surveillance epi stuff. So that kind of brought that in first. Dr. Keister got engaged because he is still the chair of the Sports Medicine Advisory Committee, so and a pediatric sports medicine physician. So link there. Some of the contacts in Australia honestly came about because I was looking for an instrument to use. They developed the instrument. We wanted to modify it, and I just reached out and said, "Would you guys be willing to do sort of a face and content validity expert review of this instrument before we use it?" And it kind of grew over time. And so, I don't claim to be an implementation scientist. I probably know enough to get myself in trouble a bit, but I do know who to kind of engage with and ask those questions. But one of the things I have learned and really like about implementation science is, in some ways, it's almost a bit of common sense. Like, oh, is it really that shocking that someone would better respond to you if you ask them what they need instead of tell them what they need? It's like, I don't, like, and so there is much more to it than that, but some of that kind of very intuitive piece is helpful. And then I do think it's helped with Sam and Mark Hoffman that we have practiced clinically. So some of that, what would a patient use, or what is useful there? What constraints would a high school athletic trainer have in their, would this be feasible? And that always pops up of trying to build those. And so just trying to reach out, ask, and let people tell you no. But I think more often than not, if you go with them with a specific reason of, can you engage because you have this skill set I don't have, I think I've had good success to people wanting to be engaged.
Any other questions?
I guess I have one question. With the athletic trainers, do they tend to not be involved in the warm-ups, or that's where you're saying it's an additional talent?
Yeah, so the athletic trainers at a high school setting typically are not going to be out there running warm-ups for teams. It's going to be very coach-driven, primarily because you have 10, 12 teams all practicing after school, and they're really present in case, hopefully they're present every day. It's not actually the case at high school, but if they are, they're really there to help initially triage injuries, and then if they were there, they're probably going to do game coverage where there'd be a higher likelihood of injury. In a collegiate setting, the athletic trainers really actually aren't doing it either, and a lot of times that falls on a strength and conditioning coach. And so there will be oftentimes communication between those staffs, but the people you see before a game on TV running the warm-ups, the coaches are the strength and conditioning coaches, and the athletic trainers handle the medical side. And so college is different. It presents some different challenges between that paradigm, between those two groups. But yeah, in the high school, it's really just because they're one person and they may have 150 athletes they're trying to deal with, they can't run through all of those pieces. But they are perfectly positioned to be able to have relationships with both the athletes, but then coaches, assuming there's not a lot of turnover. So they might not be at practice every day, but they get to know those coaches. And that's where I think they would have a better opportunity to, educate them to change a practice than some external person coming in and say, hey, coach, I don't know you, but go do these things. And so having that dialogue by someone they know and maybe have some rapport built with would be helpful.
Do you think that some of this program implementation stuff is things that should be included in like an AT curriculum? Because I know as an athletic trainer who's tried to implement something like this and had a similar experience as you with your coach and just kind of failing miserably and being shown the door, do you think this is something that we should be talking more about so that we take some of our injury prevention knowledge and actually apply it?
Yeah, I think it should be somewhere in athletic training education. I struggle about whether it fits best in professional education at first step. There's so much else they need to learn in terms of just how to evaluate or rehabilitate an injury that is this like so far removed. But from a professional development perspective, and we've had the opportunity to do some of these presentations at regional meetings or national meetings, I think that's where it fits. You've got the person, they're credentialed, they're working, maybe they're someone like you that have faced these challenges as a coach. And so this kind of education would be an opportunity to say, think about doing it in a different way. Right? And you're not going to reach everybody. There are going to be some coaches that you just won't reach. But I kind of didn't mention it. The other kind of big factor in a high school setting is the parents, right? I mean, at a certain point, there's that if you educate parents at a parents meeting about how important it is for injury prevention in girls soccer at 14 to 17, and then they go and they don't see their kid doing that, a parent can get a lot done with a question or a coach about what does that look like. So I think trying to be a little bit more deliberate in picking who you can have allies, but I don't know that it's an entry-level education piece, more so as a professional development piece. Right.
Do you think this could be done at even earlier stages? And primarily thinking like from anecdotal evidence, like baseball players that are young now that are throwing hundreds of pitches when they're 8 years old and having Tommy John when they're 10. Do you think it's possible to have some kind of intervention program where they go into the little league system or go into like those younger sports systems and kind of do some of this stuff?
Yeah, and there is evidence to suggest that, you know, doing this early on may be beneficial, especially for one of the things that tends to be seen is that the injury rate in males and females tends to be pretty similar until adolescence, and there's some thought that females go through a growth spurt and have some other changes relative to size to strength ratios that start to impact the way they move that aren't really apparent before puberty. So some of the thought is that we really want to make sure those programs are implemented before that time. I've always had this thought, but haven't gone there yet, is that the perfect place this will be done is that many of the things we're doing here are not simple, but they're movement skill acquisition. If kids had access to physical activity classes within high schools and you build them in, then everybody gets it whether they're on a team or not, because this would get to certain populations that are on a physical activity, that are on like a soccer team. But if they play club soccer, not for the high school, you're not going to get them. You tend to see in those sports in other kids who dance, right? Maybe you get an ACL injury in dance, so probably not doing a ballet teacher or whatever isn't probably doing an ACL injury prevention program. So I think there's opportunity potentially. There's a lot more hurdles in terms of physical activity, and then how do you integrate that perhaps into a curriculum? But that would be kind of, I think, an ideal setting, and you just give it to as more of a developmental piece that's there. Unfortunately, oftentimes, as depending upon the state you live in, the time when females specifically, they really need to be doing these programs at the exact time when physical education classes tend to become not required. And so you're kind of like, have these chances for these changes to occur, and they're not maybe even having exposure to that. So that'd be an additional barrier. But yeah, I mean, the more you can just make it a part of the culture of what it's done, the easier it'll be. I think it's trying to get there.
Okay, I'm not seeing any, oh, sorry.
Oh.
We have an extra minute. I'm just curious, one of the slides you show, the one with you have the awareness data, 55%. And although you have boys and girls soccer and basketball, what's happening with the boys basketball?
Yeah. So boys basketball, so I think two things are happening there. Number one, this is perceived as a girl problem, not a boy problem. And number two, especially at the time this was done, the most famous injury prevention program in the world is the FIFA 11+ pushed for soccer coaches. And I think that is contributing to the fact that there isn't like an MBA program. There has since come out some programs, basketball specific. The Hospital for Special Surgery, who works with the Brooklyn Nets, has come out with programs, but it doesn't have the cachet of like a major organization as to the NBA comes out and says, do this, which I think where some of that reach happens. And it's not happening at a coach level, like go to all basketball coaches to do that. So I think they just don't see it as an issue. They're not looking for it, and no one's telling them about it. And if they've heard about it, it's, that's for that other sport. It doesn't happen with me. Basketball is also a really hard one because your rosters are so small. So I talk about like maybe one injury on a female soccer team, but in basketball, you may have 12 players. You could go like 2, 3, 4 years and never see one of these things. And if I'm that coach, I don't know that I would be much different about, am I going to change my practice for that? But then they could also go a year and have 2 or 3 at a time. And oftentimes when that happens, they just chalk it up to, oh, that was just bad luck, right? And so it's like this weird place this injury lives in, that it's common enough that it's a problem, but it's not so common that people really need to worry about it front and center all the time. And so one of the other things that may happen is, can we do a better job to highlight the fact that these programs, yes, reduce ACL injury, but do they reduce all these other kinds of injuries? So now as a basketball, if I know it reduces ankle sprains, it's probably more pressing for me. If it's muscle strains that aren't significant long-term impacts, but if I'm a high school basketball coach and my player gets a muscle strain 2 weeks before the state tournament, I care a little bit more. And so some of the things Sam and I have talked about as ways to do that is to generate that knowledge is a lot of times this injury data is expressed in terms of rates, but we don't look at these things oftentimes in terms of injury burden. And so burden is one that I've seen used a bit in like occupational health. So not only what is the rate, but what is the time loss? And you kind of cross those two. And so something that happens fairly infrequently, but has a really, really big time loss becomes a bigger burden than something that, or likely something that happens very often, even though the impact may be smaller, could also be a big burden. And so can you maybe do some education from a burden perspective to say, look, this is what's really challenging for you. And oh, by the way, these programs or doing these kinds of things may help you eliminate all of them. Maybe it's almost like trying to show them they have a problem and they don't see they have a problem. I think that's what's happening there on this slide is that they just don't think it applies to them.
One quick comment and then a question. I was also shocked at the graph of like who does strength, plyometrics, agility, balance. Like why are you not doing that as a high school coach?
Yeah.
Like there's still 50% who aren't. That's just a comment. But I wonder, like, has anybody ever looked at just the verbiage? Like if you package the same thing up and you said, here's a performance enhancement plan, what's the
Yeah, people have gone that route. And I have mixed feelings about that approach because if you're a coach and I sell you this plan for performance enhancement, you're going to do it until when? The next thing comes along to do performance enhancement. And so personally I struggle with is if we just sell these coaches on performance enhancement, then who's to say they're going to do that thing when the next fancy shiny object comes along for performance enhancement? I think there has to be some component that this will help performance, but you're doing this because this is a problem in your athletes, right? You have this issue, and then it truly has to be an issue for them. And I think that's there. But I do think going the route to just say, oh, we'll get them to reduce injury, just we'll sell them and we'll trick them, we'll be performance-wise. I don't think that is probably a sustainable approach because they're going to switch to something else that may not look like what you need them to do than to try to see if you can get them invested in doing it for the real reason you want. And I'd rather let performance be an extra benefit.
So I'm not seeing any questions from our online participants. So before you go out and enjoy this beautiful fall day, let's thank Marc.